And we compare between pain after orthodontics and pain after extraction. There is not any significant difference. I think the table is missing. We compare the pain between two sexes also. So many patients do not want to carry orthodontic treatment because of fear. It is reported in the study by VAM that 95% of the patients experience pain after orthodontic treatment, out of which very few only experience severe pain. In our study, almost 97% of the orthodontic patients had some fear of pain and 11% had very severe pain. The study has shown that the real pain experienced by orthodontic patient is significantly much less than the anticipated pain. And I'm still thinking, what could be the reason? The level of pain is different among male and female patients. The anticipated pain seems to be slightly higher in female compared to male, which is not significant. However, the pain experienced after orthodontic procedure is significantly higher in females compared to males. I don't want to say that females are more sensitive, but sometimes might be the reason also. I don't know. And another reason might be many of our patients are obviously female patients also. The study by Nan et al. Has found that no difference on pain perception between two sexes. So probably it's always we can carry on this for many years. To conclude, the anticipated pain before any orthodontic treatment can be really higher than the real pain experience after orthodontic procedure. With the same procedure administered, female patient might have a little bit more chance of experiencing pain than the female. That was our study. So the take-home message from this presentation is that orthodontics is painful, or might be painful. So we have to give more attention on the pain aspect of this treatment. When we are extracting, we try to comfort patient not to give pain or painless dentistry. But in case of orthodontics, we are more concerned about biomechanics, more concerned about how to finish the case nicely, but we don't seem to be really more concerned about the pain. And pain control is better than wait for pain to occur and control. So I think we can start low-dose analgesic on our treatment, if possible. So with this, we have now another clinical research is going on that we are giving some patient placebo and some analgesic and comparing the pain scale. And I think regarding the anticipated pain, I think it's better to counsel the patient before starting the orthodontic. I think that is more important in our perspective. And thank you so much for the attention. I think I'm a little bit early.
Thank you for the presentation. Are there any questions or comments?
Thank you very much for interesting presentation. I remember that I read one review paper talking about pain. So the pain, they said that men is more sensitive to tooth pain. Okay, so I think somehow difference I don't say quality, but somehow difference the types of pain between the toothache and pain from the orthodontic treatment. And also some patient who wants to get orthodontic treatment, I don't say many, but some of them may feel a little bit anxiety or mood disorder, something like that. So those factors, I'm just wondering if those factors is involved in your result. What about your idea?
Thank you for the input. So this was it's the basic research we conducted. Now we are continuing this type of research in further, okay, I will definitely think about including stress factor, anxiety factor in our future projects. Thank you, sir.
Thanks for the presentation. I believe I did not see the data, but what was the age of the patients that you included in the study?
Actually, I think it's missing in the age was from 11 years up to 19 years.
So children.
Yes. Mainly children and adolescents and very young adults.
And did you see some difference according to the age?
I'm afraid we didn't compare according to the age.
Between, 11 and 16, where there is a gap?
Our data is not very high, just total 80 number of the patient, and those are the results we compare. I think after that we didn't compare further. I think that gives the room for further comparison also.
And for the sex difference, you said you did not have so many boys. Do you
Yes.
think that they are too frightened to come to you, and you only have the courageous ones?
I think the worldwide trend is that girls want to be more beautiful than boys. Trend is changing, maybe future we'll have more boys, but obviously in our clinical setup also, I see that more than 70% of the patients are girl, and the population is same. Yeah, but 50-50, but still girls are more concerned about beauty. Maybe the parents are also more concerned.
Thank you for an interesting presentation. So, where do your patients get the information about pain? Is it from YouTube or is it from you?
From YouTube.
It is not from YouTube, it's from you.
Because my question to you is actually, if I got it correctly, the anticipated pain was higher than what they experienced.
Right.
Isn't it so, perhaps, that if you prepare your patients for having pain in a good way, they are prepared for a high level, and when they sort of get the pain, they think, oh, there was some pain, but it wasn't that bad. Could that be one answer?
Yes, you're right. Actually, in my part of the practice, in my part of the world, as I said, we don't really think about preparing the patient, okay? And probably they hear from the peer groups or their classmates, oh, it was very painful. The doctor put some rubber band inside my teeth and I could not sleep. And still now, whenever patient come to our hospital, I say, how was your experience? I always tell, after separator, after banding, and even after the activation, I say, how was your experience? Many people say, no doctor, it was fine, I enjoyed it. And many patients say, oh, you can imagine, I had a horrible pain. It means that it's the difference, okay? And regarding the anticipated pain, I think if we better prepare the patient, the fear of pain will be less high. Will be less.
That was actually my last comment. Thank you.
Thank you so much. Thank you for the input.
Thank you.
Another question?
Thank you very much for the presentation. I have just one question. You say that we should be more careful about the patient's pain.
Right.
So you were talking about analgesic, of course, before the pain comes, and also about preparing the patient before.
Right.
Do you have something else in mind to be more careful about it?
Yes, I have three things in my mind. First is, of course, counseling before going to the orthodontic practice or orthodontic therapy. Another is low dose analgesic, because it has been already proved that high regular dose of, it's not like it's not like we cure the pain, but we stop the process of the pain. That is more important in terms of orthodontic, because we can't prescribe analgesic for next 2 years. It is not possible. But if we can stop the process of the pain, then I think it works better. And third is very low dose analgesic, not the high dose. It's already proved that high dose of analgesic causes the, even with the ibuprofen, it causes the decreased tooth movement. So we don't want to increase the treatment time. So maybe in low dose, if we stop the pain process, probably it might work. That is the 3 things in my mind right now.
Thank you very much.
Okay, thank you very much, Dr. Dashrath.
Thank you, sir.